Welcome to this presentation entitled Introduction to Evidence-Based Practice. I'm Mark A. Bell. I'm an associate professor and co-director of the Institute for Evidence-Based Health Professions Education at the University of Georgia. This program is part of a series from the College of Public Health and the Georgia Public Health Training Center. Before beginning, I'd like to disclose some potential competing interests. I'm editor-in-chief of Essential Evidence Plus, a publication primarily online from Wiley-Blackwell. I'm also deputy editor of American Family Physician, the educational journal of the American Academy of Family Physicians. I'm co-editor of Essentials of Family Medicine, which is a textbook for third-year medical students. And formerly, I was editor-in-chief of the Journal of Family Practice, at the time a research journal in primary care. So you'll often hear folks say, we have the greatest health system in the world in the United States. You have to wonder, greatest what? Is it the greatest number of MRI scanners? Do we have the most uninsured? Are we greatest because we spend the greatest amount of money of any country, which is unfortunately the case? Do we have the highest physician salaries? I think if you look at the data, it's clear that we do not have the greatest health system in the world in terms of the overall quality of care, and certainly in terms of the value that we get for what we spend on healthcare in this country. In fact, let's take a look at this graph, which is from the Organization for Economic Cooperation and Development. This shows the cost per person for healthcare along the y-axis on the left, and you can see that the United States is at the top there. At the time, around $5,000. These data are now about 8 years old, but the general principle has remained the same. If you look into the center of the graph, you can see where most countries are. That is, they spend a moderate amount of money and they have a moderate number of healthy life years. Unfortunately, the U.S. is in the wrong part of this graph. We're in the upper left corner where we have fewer healthy life years and spend a lot more money. This has led a lot of folks to question how we organize care in this country. What are we paying for? Are we getting value for our money? Are we spending our healthcare dollars on things that are most likely to help people live longer, healthier lives? So too often, the care that we deliver is built around technology. It's quite expensive. It doesn't improve how long or well patients live, or does so only very marginally. We might spend $50,000 to extend someone's life by a few weeks or a month. And often what we do is even inconsistent with the best available evidence. Someone once said, when all you have is a hammer, everything looks like a nail. We have a lot of hammers in this country in healthcare. And this realization that we're not getting the best value for our care has led to what's called the evidence-based practice movement. And today we're going to talk about evidence-based practice. We're going to define it, going to give some examples, and going to show hopefully how you can make it a practical part of your day-to-day work in healthcare. Let's begin with an example. Regardless of what you do in healthcare, if you're listening to this program, you might be a public health professional, a physician, a nurse, physician's assistant. You might be interested in health policy. You might work in a health department. Lots of different things we do in healthcare. But all of us have gotten sick once or twice in our lives, and many of you have probably gone to see the doctor when you had a cough. So let's think about what happened. What test did the doctor order? How did they examine you? Did they get a chest x-ray or some other kind of evaluation? What kind of treatment did they recommend? Did you think the treatment was effective? How do you know? And how long did that cough last? Let's consider a pretty typical case. We have a 52-year-old man who's otherwise healthy. He's a non-smoker. And for a couple of days now, he's had a cough that's produced some green sputum. Everyone knows that's bad. And he's had a low-grade fever of about 99.5 Fahrenheit. On exam, his blood pressure, his pulse, his respiratory rate are normal. And when you listen to his lungs, he has a normal lung examination, no crackles or wheezes or anything. His wife started him on an herbal extract called Pelargonium sidoides, and he wonders whether he should continue taking it. So what would a typical clinician do in the United States? Well, if they were in an urgent care center or if they were in the emergency department, they might very well order a chest x-ray, particularly urgent care centers where there's a financial incentive to do that kind of testing. Most physicians would prescribe an antibiotic. The most recent research shows about 2/3 would prescribe an antibiotic for a patient like this. They might prescribe a cough medicine that contains hydrocodone, something like Hycotus. And it's doubtful that they'd recommend Pelargonium pseudoides. Okay, that's not something they typically would know about. So let's examine each of these things one at a time. First of all, chest x-ray actually isn't necessary in this patient. There were 2 large prospective studies of over 1,400 outpatients who had a cough. The only ones that had a pneumonia, which is what you're looking for with the chest x-ray, were those who had a temperature over 100 degrees, an elevated heart rate, or an elevated respiratory rate, or they had at least a couple of things abnormal on their lung exam. They weren't asthmatic and they maybe had some crackles or a change in their breath sounds. Our patient, remember, had none of these things. So pneumonia would be incredibly unlikely, and we really don't need that chest x-ray. What about antibiotics? I think it's commonly believed, certainly among a lot of patients, that antibiotics are absolutely necessary when you have a cough, especially if you're coughing up green sputum, have a low-grade fever. Actually, that's probably not the case. The best study to date was a randomized trial of 200 otherwise healthy adults who had a cough, and about 2/3 of them had green sputum, about 2/3 had some degree of fever. None of them had pneumonia. They all had a chest x-ray to rule out pneumonia for this study. And what they found was that those randomized to low-dose vitamin C, essentially a placebo, had exactly the same outcomes as those who got the Z-Pak. 2 weeks later, they were all doing much better, almost all doing much better. No difference in any clinical outcomes. A systematic review looked at all the evidence, and even though some of these studies were fairly low quality, which might introduce some bias, at best you have 12 hours fewer symptoms with antibiotics, and you trade that off for more adverse effects, diarrhea, stomach upset, things like that. So Z-Paks are not necessary for acute bronchitis. All right, well, what's the evidence for cough suppressants? Surely there's a rich body of literature to inform that. Actually, there isn't. Surprisingly, there have been no randomized controlled trials comparing hydrocodone as a cough suppressant with placebo in patients with an acute respiratory infection. None at all. There have been a couple of little studies in patients who are just coming out of anesthesia. When you pull that tube out, it can leave them coughing sometimes, but that's about it. So we really don't know. We think that hydrocodone works. It certainly will make you sleepy, and it probably helps a lot when you're trying to sleep at night with a cough. But how well it works for its antitussive effect, we really don't know. And that's the case with a lot of the things that we do in healthcare, is we think it works, but we're not really sure we know it works. And finally, what's the evidence about that crazy herbal stuff? Well, it turns out that there have been a number of randomized trials showing that Pelargonium pseudoides appears to be safe and is actually significantly more effective than placebo to relieve the symptoms and duration of acute bronchitis in adults and children. The studies aren't perfect. We probably need a few more studies, but it really looks very, very promising and certainly much more effective overall than the antibiotics. So sometimes we can be surprised, and the fact that these are a little bit alternative, a lot of physicians may not know about it, the evidence is actually pretty good. So this case illustrates the discrepancy between usual practice in healthcare in the United States and what the evidence supports. Chest x-ray wasn't necessary for our patient, but had he gone to the urgent care center or to ER, he might very well have gotten one. Antibiotics don't work, but most physicians would have prescribed one. Hydrocodone probably would have been prescribed, but we really don't know how or how well it works. And something that probably does help is very unlikely to have been prescribed. So maybe doctors are just stupid. Maybe Jerry Lewis was the prototype and the people on Scrubs are how it really is. Well, actually, physicians are not that stupid. If this is data from Great Britain showing IQ by profession, and you'll see that physicians are near the bottom of the graph and near the top of the IQ chart. Of course, it's also important to note two things. One is that they are ahead of legal occupations, which makes me very happy, lawyers and attorneys and the like, but also that the lower end of the IQ scale for physicians overlaps with every other group, so no one group is always smarter than another. Physicians may think they are, but often physicians and other healthcare professionals do things that when we actually look at the evidence, don't appear that smart. So the next few slides, we're going to think a little bit about cognitive science and why is it that smart people sometimes do dumb things. Cognitive science thinks about how we think, and it has grown out of work in the military, looking at decision-making under pressure. A lot of research has been done on pilots and how they behave in an airline cockpit, how the crew interacts. There have been studies in surgical suites. One of the things that we've learned is that information overload is a big problem. Inconsistent adoption based on tradition or expert opinion or culture rather than evidence happens. There's an over-reliance on informal observations. There are different kinds of bias that creep into the data we look at, and we often use and rely on pathophysiologic reasoning in healthcare, sometimes to the detriment of our patients and clients. So we'll go into a little more detail on each of those in the next 5 to 10 minutes or so. So information overload is the first thing to talk about. Each year, there are over 20,000 articles written just in the top 100 clinical journals, and there are thousands of journals out there. Randomized controlled trials are shown in the graph. Back in 1987, when I graduated from medical school, there were about 4,000 randomized trials done every year, which is a huge number. But that number is now approaching 18,000 randomized trials per year. You really need some sort of filter to figure out what's the most useful information. You obviously can't pay attention to all of it, and when you're answering a question, you need to be able to quickly find that highest quality, most useful evidence. And it's especially a problem because those of us in healthcare often spend a fairly limited amount of time reading to keep current or to keep up to date with the literature. Research shows it's generally between 15 and 60 minutes per week reading to keep up. And while we'd like to think we do more, we're all busy people. We all have families and interests, and I think it's not unreasonable to hope that we should be able to keep up with that 30 minutes per week. So we're going to talk about some strategies today for how you can do that. This is a graph from a study by Elliot Antman published in 1995, and he was looking at the adoption of clot-busting drugs, thrombolytics, for people who are having a heart attack. And the very first study, as you can see looking at the top of the graph, occurred actually in 1959 and had 23 patients. And over time, evidence accumulated. More and more studies were done. By 1973, there had been 10 studies with 2,500 patients, and it actually showed a significant benefit favoring treatment. That's the first red circle near the middle of the screen there. But if you look at what textbooks and review articles were recommending, it took another 15 years before most textbooks were routinely recommending this very effective therapy. So there was a lag of about 15 years, and this has been seen in a number of other cases. So sometimes the adoption lags behind where it should be. We don't use effective things. The opposite can happen too, as with antibiotics for bronchitis. We continue to do things despite good evidence that they're not effective. Part of what drives this inconsistency is the fact that we often rely on what we've always done, what the experts in our local community tell us, what our colleagues around us are doing because we want to fit in. The Japanese say the nail that sticks out gets hammered down, and that's true in medicine as well. People tend to practice kind of like the other people in their community, and that can lead to some wild variations. This graph from the Dartmouth Atlas for Healthcare shows the rates of surgery for spine problems, lumbar fusion, which is a type of surgery in the U.S. The blue areas have much higher than average rates. The green areas have much lower than average rates. And you really can see some regional patterns here. Clearly, the Northeast and much of California and the Northwest have significantly lower rates. Out west, parts of Florida, parts of Texas, you see much higher rates. It's particularly striking when you compare some individual communities. Idaho Falls, Missoula, Bradenton, they have rates about 20 or more times higher than those for Grand Forks, Covington, and Bangor. So there's something going on here. Those communities aren't necessarily that different in other ways. And again, we're only limiting these data to Medicare enrollees, people over 65. So it's not just that they're more older people in Florida. We've adjusted for that. So you really have to wonder what's going on to drive these very high rates in some communities and very low rates in other communities. There's some other important cognitive biases, and they're grouped under over-reliance on informal observation. We tend to give too much credence to what we see with our own two eyes in practice. And an example is we're biased toward what we've seen or heard recently. If we just saw a lecture on a rare condition, we're probably more likely to order tests for that condition in our practice. We're also wired to see causality, even if it isn't there. And so when two things happen together, a patient comes in, I give them an antibiotic, a week later they're feeling better, the patient and I both want to believe that it was that antibiotic or that shot or that injection that made them better. We don't systematically observe outcomes in practice. Okay, we don't systematically ask all of our patients who got an antibiotic, are you feeling better 2 weeks later? And so sometimes a study will tell us that antibiotics, for example, don't work for acute bronchitis, but we tend to discount that and value what we feel we've observed in our practice, which is that my patients get better and I gave them an antibiotic, so it must have been the antibiotic, and that's unfortunately turns out not to be true. The final point is rare outcomes are rare. We are not wired to be able to detect an increase in mortality of 1 per 100 patients. But that's obviously an important thing. If 1 out of 100 more people die each year, we'd really want to know about that. But it's very, very hard for an individual clinician to observe that in their practice. And increasingly, we're seeing bias. Some of it's unintentional. The study might have been too small. An observational study isn't able to figure out about causality. It isn't able to determine whether an intervention caused an outcome to happen. It can tell us about associations, but it can't tell us about causation. There are also intentional biases. Industry-sponsored studies are very, very common. Much of medical education is now sponsored by industry, and there are tricks that you can use in designing a study to make it more likely that your drug or your treatment or your procedure looks effective. Straw man comparisons, using a weak or ineffective comparison drug to make your drug look better. An active run-in period. One of my favorite examples was a comparison between Prilosec, which was the, at that time, little purple pill, versus the older generic drug Zantac. And they only allowed people into the study after this active run-in period if they had taken the Zantac and it failed to help them. So only people that failed Zantac got into the study in a comparison of Zantac with Prilosec. Well, that's setting Zantac up for failure, of course. Other things that they do is they don't blind appropriately. There are games with randomization. So we really have to be on the lookout and make sure that every study is objectively evaluated for these kinds of potential biases. And finally, we often fall back on pathophysiologic reasoning. A lot of healthcare education, whether it's nursing school or medical school, is based on biochemistry and physiology and anatomy. And so we look at what the underlying physiology is and we say, hey, if we fix the physiology, the patient will always do better. And that just isn't true. Vertebroplasty was an example where the anatomy of the problem would make you think that injecting this cement into the bone to strengthen it would help patients. Turned out it didn't work. Lower blood sugar in type 2 diabetics should be always a good thing based on the pathophysiology, but 3 large recent studies have shown that very strict control of blood pressure in many cases is actually worse, and in one study increased mortality significantly over more moderate control. Suppressing abnormal heart rhythms after heart attack. We thought that was a very good thing to do in the 80s. There were tens of thousands of excess deaths due to complications of use of these drugs, which did not prolong life. So we have to always be certain to look at the patient-oriented evidence. What are the real clinical outcomes a patient would care about, and not just what's the pathophysiology. I'm going to illustrate those limitations of pathophysiologic reasoning a little bit more using the example of vitamin E. When I was in medical school, residency training, I was taught vitamin E is a great thing. It's an antioxidant. The pathophysiology sounded great. It prevents platelets from sticking together. It's going to prevent LDL cholesterol from oxidizing, and nobody wants rusty cholesterol in their bloodstream. It should do all sorts of good things for heart disease, cancer, Alzheimer's, you name it. And the pathophysiology was very seductive. The first evidence came from observational studies, and they showed that patients who had heart disease, they measured their vitamin E levels, they had lower vitamin E levels than patients who didn't have heart disease. And patients with heart disease were less likely to have taken vitamin E supplements than controls. But again, these kind of studies can't prove causality. They can only show associations. There are lots of reasons why you might imagine patients who have heart disease are different from those who don't in terms of their habits, the medications they take, their diet, other things that might affect these vitamin E levels. Maybe it's just a marker and really doesn't have a causal effect. The first randomized controlled trials were done in the early 2000s, and they showed that there was actually no benefit. Vitamin E, patients randomized to vitamin E or placebo had no reduction in the risk of cardiovascular events or mortality. So these large studies showed that it didn't work. Nevertheless, a lot of folks said, well, maybe it doesn't work in those patients, but maybe it works in my patients. So a lot of folks continued to give or recommend vitamin E. Millions and millions of patients were taking vitamin E at one point, and many continue to take vitamin E despite this lack of evidence. And the final piece of evidence comes from a meta-analysis. Meta-analyses combine data from multiple randomized controlled trials, in this case 19 randomized trials with over 23,000 patients, and they found a dose-response relationship between increasing vitamin E use and increasing mortality. In fact, for every 300 people who took more than 400 IU per day of vitamin E, there was one extra death. So at best, vitamin E does nothing. At worst, it may actually increase all-cause mortality. So what happened? Pathophysiology sounded great, all that rusty LDL and platelet adhesion. Lots of experts recommended it, but they were wrong. There were observational studies that were promising. They turned out to be wrong. They showed association, but it wasn't causal. Everyone was focusing on these disease-oriented outcomes like vitamin E levels and antioxidant levels. The non-confirmatory evidence was initially ignored. It didn't fit the current paradigm. It didn't fit what local culture and local practice patterns were teaching, and so it was ignored quite often. And the adverse events, if there are actually one extra death per 300 people, it was too rare to see in practice. So it's a good example of where we were misled by a lot of these cognitive biases, and we really, teaches us that we really have to rely on well-designed clinical trials when we're trying to decide whether or not something works and whether or not something is safe for our patients. So you'll often hear researchers and teachers and clinicians say, I really believe that works. And at that point, I think we have to be careful. We're usually extrapolating from the pathophysiology. We're really operating at a level of faith. I think that something works. Maybe there's some initial or preliminary or what people like to call emerging evidence. But again, we have to be cautious. Thinking that something works isn't the same as knowing something works. And we only know something works when we have well-designed, randomized clinical trials that measure patient-oriented outcomes and show that doing something or not doing something helps someone live a better or longer life. So we've just spent quite a bit of time talking about some of the limitations of how healthcare professionals gather information, process, use information, and why that sometimes leads to decisions that aren't consistent with the best available evidence. The idea that we should base our practice on the best available evidence is called evidence-based practice, and it really began to emerge a couple of hundred years ago. Some of you may have heard the British referred to as limeys, and we'll learn why they're called limeys in the next slide. One of the problems of long ship voyages was that scurvy was common. It was vitamin C deficiency, but they didn't know what caused it. There were a lot of theories. There was a lot of speculation about what caused it. The fellow in the slide there is a British sailor of the 1700s, pale skin, sunken eyes, loss of teeth. Those were all characteristics of scurvy, weakness, and fatigue. So Dr. James Lind was a British surgeon in the Royal Navy, and he was assigned to a ship. And he noticed that 12 of the sailors had scurvy. And he decided once and for all, I'm going to figure out how to fix this. And he really did what many people consider the first clinical trial. One pair of sailors got extra rations of rum because some people thought that would be a good thing. We call those sailors the lucky sailors. Another pair of sailors was given rations of seawater, salty seawater to drink. We call that the unlucky group. Another group got extra fresh air. Another group got various other potions and liniments. And one group got 2 oranges and a lime. And it turns out that they were very quickly cured. Within a week, they were caring for the other 10 stricken sailors. And yet it took 50 years for this to be adopted as routine practice by the British Navy. But this was really the first clinical trial, and we have Dr. James Lind to thank for that insight, which now seems absolutely self-evident to us, but at the time was revolutionary and was really the first step toward evidence-based practice. Now we can get smug and say, well, boy, how silly that they wouldn't adopt that for 50 years. But remember this graph we saw earlier. Clot-busting, incredibly effective drugs for acute myocardial infarction took 15 years to adopt those. So this same failure to adopt new therapies and failure to abandon ineffective therapies has been plaguing us for hundreds of years. As we think about the history of evidence-based practice, there are a few pioneering people and institutions that have been really important, and I think it's important you know about them. Archie Cochrane was a British epidemiologist, and he had the insight that in the 1950s, as we started to do clinical trials, really the first modern clinical trials were done in the 50s in Britain, he said, well, into the 60s and 70s, he started seeing hundreds and even thousands of these clinical trials being done. He said, wouldn't it be wonderful if every clinician had access to every clinical trial ever done so they could inform their practice with the best evidence? David Sackett was a Canadian internist at McMaster University, and he first coined the term evidence-based medicine and then expanded it to evidence-based healthcare or evidence-based practice. And he led the McMaster University group that really pioneered a lot of the thinking about evidence-based practice and thinking about how to design the most valid studies that are most likely to be free from bias. And that's going to be a really important theme. He also had a series in the journal JAMA on how to read the literature that was very influential. And finally, the Agency for Healthcare Policy and Research, now the Agency for Healthcare Research and Quality, was established in the early 90s, went through a near-death experience when they tried to promote evidence-based guidelines that, as it turned out, were inconsistent with the practice of, in particular, spine surgeons, and led to nearly being defunded because the belief in what the spine surgeons were doing was greater than the evidence. And they fortunately survived that and have really been pioneers in evidence-based practice, and in particular, the U.S. Preventive Services Task Force, a very important basis for much of the public health practice in our country, is part of AHRQ. So here's my definition of evidence-based practice. It means that we are making a conscientious effort to base clinical decisions on research that's most likely to be free from bias, and using interventions most likely to improve how long or well patients live. So let's break that down. Conscientious means that you are a thoughtful healthcare provider, that you think and care about these decisions, that you question the current practice and are willing to make an effort conscientiously to do the work to make sure that what you're doing is best for your patients or clients. It's also important to know that this definition is probabilistic. There are very few certainties in healthcare, and we really are trying to focus on what's most likely to be free from bias and what's most likely to improve how long or well our patients live. So evidence-based practice is inherently probabilistic. The focus is, of course, on trying to identify the best available evidence, and we define the best evidence as that which is most likely to be free from bias. And remember, there are intentional biases, there are also unintentional biases, and it really has to do with how well we design the study to try to determine the truth. And finally, the focus needs to be not just on evidence that a drug will lower blood pressure or lower blood sugar, but rather that it will improve how long or how well our patients live. That's what makes it truly relevant to healthcare. Anytime you tell a bunch of people, like healthcare providers, that they could do better, that they're not doing as well as they possibly could, there's bound to be a bit of a backlash, a reaction against that. And evidence-based practice has been criticized for being cost effectiveness in disguise, and that's not true. The focus, while it may be more cost effective, the focus is on improving the quality of care and improving healthcare outcomes, not necessarily on reducing costs. It's also criticized for being cookbook medicine, or that computers make the decisions for us. And again, that isn't true. A poorly designed guideline may look like a cookbook, but any chef will tell you a cookbook is just a guide. And it does tell us what the usual best practices are, but there's always room for application to the individual patient's needs, and we always have to remember to integrate that evidence with the patient's values, so we make sure we're doing the best thing, not just in general, but also for that patient. And when we think about computers and algorithms and decision support, again, we have to remember it's decision support, not decision replacement. And finally, I don't think it's taking the art out of medicine, but I think it is providing a balance of science and art in the practice of healthcare. And I think if we are thoughtful about how we apply the evidence and make sure that we integrate it with patient values, we improve the outcomes for our patients and clients to their benefit. Recently, there's been a lot of talk about comparative effectiveness research. And really, at its core, comparative effectiveness research is evidence-based medicine or evidence-based practice. And yes, it is actually a kind of rationing. And I would ask you to consider, how should we ration healthcare? I think we all probably agree that we can't do every single last possible thing for every single person. And in fact, we shouldn't, because a lot of these things are harmful and aren't very helpful. So should we ration that care by where you work, or who you were, how you were born, or where you were born, or your race or class? Or should we ration it by allocating resources to those tests and treatments that are most effective and that actually help our patients live better or longer lives? And that's the goal behind comparative effectiveness research, is figuring out what works and what doesn't work, so we can make the best use of our healthcare dollars and also have the best chance of providing a net benefit to our patients. And evidence-based practice has expanded beyond the realm of medicine and beyond the realm of the individual patient into other parts of healthcare. We now think in terms of practice guidelines to guide the care of populations. Increasingly, we encourage healthcare providers to think about their panel of patients, or that group or community they care for, and not just the individual. We also think about screening and prevention at the population or community level, and we want to develop policies and guidelines that are evidence-based, so we make the best decisions about when to screen, when not to screen, when to try to prevent disease and when not to. Health promotion interventions, exercise, diet, interventions at the community level. Increasingly, researchers are looking at the evidence and trying to design evidence-based clinical trials to figure out what works best. One of the challenges that